Well, thank you, Celeste, for supporting us from a technical perspective. Hello, everybody. This is the third President's Dialogue from GAME. My name is Eva Thalmann. I'm currently the president of GAME, which is an honor for me. And so I have the privilege, actually, to always talk with world experts in learning about topics you are interested in, because we know it from our member survey, but also I'm interested in. So this is a really good position to be in, I can tell you. But before we start with the introduction of the panel, I would love to ask all of you, we have the chat function open. And what I really would like to know from you is if you think about meaningful outcome measurements in CPT. What does meaningful outcomes mean for you? Please use the chat, put your thoughts in. This is really interesting for us, also then for the panel discussion. And I have to say, this is, I always say it's my all-time favorite topic, but today it is my all-time favorite topic. We are talking about outcome measurements in CPT, CME, and lifelong learning in healthcare. And that's something which is important for all of us, independent of if you are working in academia or if you are a medical education agency or if you are working in industry. And hence what we have is a really nice panel and expert faculty. My co-chair is Mila Kostic. Hi, Mila. Mila actually was an educational expert at the University of Pennsylvania and in Stanford. She has a very broad experience in the whole academic environment, focused on scholarships in CPT, communication in healthcare, motivating for learning, and communities of practice. So a really broad experience. And I can say from my own experience, actually knowing her since a few months, I already have learned so much from her.
That's too much, Eva. Thank you so much. It's great to be
No,
here.
it is
But
true.
put that in the context of CPD,
No,
maybe I have some experience.
I always learn from you.
Not expertise.
Whenever we actually talk. Then actually, I'm really, really happy and very grateful for Professor Weiss, who is a professor of family medicine at the University of Colorado. And he is also Chief Learning Officer and Senior Advisor to the President and CEO of the American Board of Family Medicine, and also an expert in lifelong learning in healthcare. Professor Price, thank you very much for accepting the GAME invitation. We are so happy to have you here.
Good morning. Thanks for me. Good morning. Good day for everybody. Thank you so much for inviting me. It's nice to see some familiar faces and some new faces, and I look forward to the conversation.
Yeah, and thank you for getting up so early, because I think you are in Denver, right? So it's very early in the morning. And last but not least, a very dear friend of mine and former colleague, Cristina Loriente, is Head of Medical Education at Janssen, and she is covering the regions Europe, Middle East, and Africa. And her team is not only responsible for Janssen provided medical education, but also for educational grants in this region. So she has a very broad perspective. Hello, Christina. It's lovely to see you.
Hello, Eva. Thank you very much for the invitation. I'm really happy to be here with all of you. Thank you.
I have to excuse Miriam Ullmann. She got sick yesterday and she cannot move. So this is why I have to excuse her. She says hello to everybody, and I hope we will have her in one of our future programs. So, do we have already comments in the chat? Everybody, please chat away of what meaningful outcomes, what does this mean for you if we talk about outcomes? So, with this, actually, I hand it over to you, Mila, to kick off with the first topic we had in mind when we were thinking about this session.
Thank you, Eva. And thank you all for joining us, and welcome to this conversation, I hope. So that's the question, right? What are the meaningful outcomes? And since I've met David many, many years ago, and it was sort of in the context of quality improvement marriage with CME, CPD at the time, I want to ask you, David, when you put your hat on from all these multiple stakeholder perspectives that you have been involved in and currently are involved in, what do you think of? What first comes to mind when we think about meaningful outcomes?
So I will probably say a lot today that it depends. In this case, I believe it depends on the problem that you're trying to solve. So many of you know that one of the tenets of adult learning is that it's problem-oriented. And so when we are doing our needs assessments in CPD, we are generally trying to address a problem. I'm going to set aside for a second in this discussion, there was this new guideline released, and it's totally new information that nobody knows about. So the job in that particular case is to disseminate the information. But by and large, for most of what at least I do in CPD and I'm involved with, it's really trying to take something and make it better. To that end, that's something for those of us who are actually out in the real world providing healthcare, that's something relates to improved health of patients and populations. So Don Moore and Joe Green and Harry Gallus in 2009 published in the Journal of the Continuing Education and Health Professions a very nice model, a hierarchy of outcomes, which hopefully some of you are familiar with. And at the very top of the hierarchy, it's community health and then patient health. And then we get down into patient to processes of care and so forth and so on, down to knowledge and things like that. Unfortunately, or challengingly, which could be a good challenge for some of us, the higher you get up that pyramid, more toward patient health and community health, the harder it is to, more complicated it is to show an outcome. So there's a whole line of discussion there about what we do in CPD to contribute to that outcome rather than attribute our work directly to that outcome. But by and large, what we're trying to do is solve a particular problem in order to make the health of patients and communities of patients better.
Thank you. Thank you very much. I also know that you focused, at least lately, in your publications and in some presentations on the healthcare system as a large. And so patients certainly are part of that, but also how we integrate with CPD continuously in that context. And so I'm sure we'll talk more about that element, but maybe talk a little bit about the system context.
Sure. So I realize that system means different things to different folks in different parts of the world. In the United States, we have a lot of large healthcare organizations that are composed variably of a collected group of medical offices, a collected group of hospitals, some insurance companies, what have you. In different parts of the world, it might be a whole provincial healthcare delivery system, for example, or a whole government system, or it can be just a hospital. But nonetheless, in the United States, over the last 20 years or so, we've noted that more and more physicians in particular, but healthcare providers in general, clinicians in general, are employed now. And they work in these big, mostly complex systems that are also trying to improve the health of the patients that the population that they take care of. So there's this alignment piece that Mila alludes to that Dave Davis and Gary Filerman and I have written about, that says one of the things we need to think about in our CPD offices or our CPD departments is to make sure that we're aligning with others in the system, whether they be people responsible for quality improvement or patient safety or managing cost, or just outreach to patients or managing healthcare disparities. Make sure that we work with those individuals rather than in parallel with them, because these higher level outcomes of population care are so hard to get at. We need to team up to do it. And it's very unlikely that within the CPD unit, a single individual or department has this expertise to really do this kind of work by itself.
Thank you. Thank you. Yeah. So let's look at different stakeholder perspectives. And I would like to invite you, Christina, to talk about the perspective of the funder or the industry representative. And I know that outcomes are really important in the grant processes and in what you do in order to support a meaningful CPD that you fund. So when we think about meaningful outcomes, what comes to mind from your perspective?
Thank you, Mila. When I think in, and when we think in meaningful outcomes, in everything we do in medical education, let's say the first one that comes to my mind, and probably aligned with what some attendees are just putting in the chat, and maybe we can discuss later. The first one is how much the knowledge that we deliver or we share impact or change the daily practice for HCPs or for researchers that attend our activities, let's say, or the activities that we fund. This is important, and I put this in the first place because in the end, everything that we do is to impact and to patients' lives, and to, in the end, to help HCPs to have the best decisions and the best information to make the best decisions to impact patients' lives. And this is why I think that this is the main and the first meaningful outcome and measurement that we want to measure, and it's not easy, and maybe we will discuss later, but it's something that we need to look for and to have the best way to measure. This is the first one, and probably the most important one, but also something that it's important, thinking in outcomes of what we deliver and what we do, is we need to understand and to measure if the predefined learning objectives of the activities that we deliver, we support, fulfill. So it's important to make clear at the beginning what are the learning objectives of everything that we do, and then to see if we met these predefined learning objectives. Another important thing coming from the industry in everything we do, and I think probably most of the people can make their comment, but something that we want to measure and we need to measure to maintain the credibility of everything that we do is what is the level of scientific objectivity in everything we do, which is important coming from the industry. So these are, I think, that the top three meaningful objective measurements that I could point out, probably to continue the discussion.
Maybe if I'm allowed to drop in, Mila, and I'm going back to one comment which actually says here, meaningful outcomes are also measurable outcomes. And then David actually said, can we in CPD, what can we measure and which level of the pyramid can we reach with a CPD or CME event? I have the feeling, and I would love to understand, what you think, that sometimes we are aiming too high, and a 1 hour seminar might not be able actually to really have an impact on a health system, right? So David, maybe if you can, help us a little bit, I think a lot of us here, if I see a lot of colleagues from medical education, from the medical education community, we are working with 2 hour satellites, we are working maybe with a masterclass, which is a day, we have an hour webinar like this. So what do you think? What is really measurable? What are the levels we can reach with this kind of time? And maybe also, do we need special designs?
So thank you. I'd like to flip the question a little bit. This sort of relates to, we have a CPD activity, what can we measure? I'd like to flip the question a little bit and think about how we can design CPD to get the outcomes we want to get at. So in other words, start with the desired outcomes and design the CPD rather than do the CPD and figure out what we can measure. That's a little bit of a mind shift, and it's been fairly recently for me as well to get into that mind shift. With that, I think, Eva, you're absolutely right. It is highly unlikely that a 1 hour or a 2 hour meeting in person, a Zoom meeting, a satellite symposium is going to affect those higher level outcomes. One of the American term is soapboxes, but I talk about this a lot lately, is the problem with one and done CPD. So a single activity, whether that be a podcast or a meeting like this, one and done is not going to change complex problems and address population level outcomes. So if that's really what we want to do, I've started to change my language to move from a CPD activity to a CPD intervention, longitudinal over time, that mixes the sort of things we are traditionally doing along with linkages to quality improvement activities where people can take what they've learned, implement in practice, come up with some learnings, come up with some more barriers that feeds more education, that feeds more improvement. And over time, that longitudinal series of events helps lead to those sorts of outcomes. Now, that's very time consuming and very difficult, and a subject for a lot of papers and a lot of discussions and a lot of meetings. So I think from a practical level, and I see some of the comments like this in the chat, we can't do that right away. So if we're going to start with the single CPD activity, realizing that we might want to have a series of events that lead to those higher level outcomes, what are we going to try to tackle with this first CPD activity? For those familiar with logic models or things like that, one can draw a little diagram, if you will. If I do A, I expect to improve B. If I do then B, I expect to improve C, and so forth and so on. And you can start with that particular activity and what the gap is. So if there is a gap in trying to improve patient population health that relates to somebody doesn't know what to do, there's a gap in declarative knowledge, then you can start with your first CPD activity on just improving that knowledge. If it is not so much declarative knowledge, in other words, if I were to get a multiple choice test, I would get all the questions right, but I don't know how to do it in practice. Your CPD activity might consist of getting a team together and talking about case-based scenarios and understanding when to do something and when not to do something, and then talk about how to do something. So you can break down these various levels, realizing that one CPD activity may be one part of a longitudinal intervention. And you might want to start with knowledge or different types of knowledge, and then have subsequent activities that get to, let's do a workplace-based CPD, where people are trying to do this in practice and learn from it. I hope that makes some sense. I'm trying to be as concise as I can to not monopolize the conversation this morning, but those are some preliminary thoughts about how we might start breaking this down.
Eva?
Yeah.
This is Lou Miller. Can I interrupt just to offer a suggestion, or do you want to hold that till later?
Do you have a question, Lou? Then just...
I don't have a question. I have a proposal.
Okay. What is your proposal?
There is a vastly unused resource that we don't pay attention to, and that is data. Everybody else in the world uses data to guide their activities, whether it's a machine tool or a trip to the moon. And we don't. In the United States, there's an organization set up by the federal government more than 10 years ago called Regional Health Information Organizations. These organizations, to a varying degree, state by state, collect all of the medical record data that can be possibly gained from all resources, individual doctors, hospitals, and so forth. These data are merged and produce results which so far are used to reduce costs of Medicare and Medicaid. It's a completely unused resource for people in CPD because you can narrow down by zip code or postal code, and you can examine what are the health problems within that population area. And then you can begin to set up programs that address those directly. We shouldn't have to fumble around to find the locations and the types of subjects to deal with in population health when we have that information in front of us. Enough.
Thank you, Lou. That's a really good point that connects us, to the important beginning of the outcome story, which is the needs assessment, right? So looking at the patient health to start with so that we can compare it to the end result. Of course, we run into all kinds of issues of attribution, contribution, and association with our educational or learning initiatives when we do that, but that certainly is an important element. And the story about data use in CPD and CE is one that I've been thinking about and hearing about and learning about and trying to do for at least 15 years. And I know there are others in the group who've done it even longer. And it's not easy. It's really not easy to connect meaningfully the intervention and the group of learners to the meaningful outcomes and health outcomes. So there is access issues, there are all kinds of other issues, there are trust issues. And I just want to maybe point out a series of papers that come from a Canadian group of authors and researchers headed by David Wilger and Sanjeev Sokalingam and others who have tried and published a big piece of research that talks about the systemic and cultural, sociocultural issues that they have discovered that relate to the use or lack of use of data in this sense. There will be something on the SACNI website soon about that as well, and I invite you to look at JSEP. So go ahead.
And I think measuring, data, getting data together might be different between the different stakeholder groups. And I would like to bring Christina from the industry side back in. I know we have, in the industry, we really have a hard time in looking what is really the impact in daily clinical practice, because this would be already a study, right, Christina? We look at it, you have a lot of data, just if you look into your team, you have a lot of data. But question also is, who can do what and how can we work together in a way? I don't know, Christina, if you want to elaborate more.
Yeah. I think this is a really important point, Eva, and it's something that I think I point out at the beginning, how complex for us is to have an objective way to measure the impact in clinical practice. Because in the end, and probably what we have currently and the way that we measure, and probably we can learn a lot from all of you, is we make these questions to the attendees of the activities or the activities that we are doing, and we make them the question just right after the activity on how much what they have heard may impact in their clinical practice. And this is really subjective. Let's say it's not objective. It's just right after. We are not measuring few months after, the activity or the intervention, as we can say. So it's something that at some point needs more objectivity, and it's super complex for us to measure and to really know the real impact, because we don't have any data, and we are not using, as far as from Janssen, we are not using any external data to understand the impact in clinical practice. And this is something that is super needed and we don't have right now, because we are just getting the questions from the attendees in our activities. So this is complex, and I don't know if anyone else has any way or any idea in how can we measure the impact apart from getting the information from the attendees at that point.
Thank you, Christina. I think you've really brought an important point that maybe it's time to talk about. So what is it that we measure, and we measure across all of our activities, always the same questions, whether it's a test of knowledge or we're talking about changes in practice, which we usually have a proxy for that, some kind of self-reported self-assessment in terms of intent to change questionnaire. And so how far does that really get us? And in the context of what David was talking about, so it's the idea of the longitudinal structure of learning interventions that lead to lifelong learning changes. Is it really time to think differently about the instruments we use when measuring outcomes? And if that's our goal, is it maybe, are there ways to use softer instruments, to use qualitative instruments, to use, interviews, to use peer observation, to use other tools at our disposal that in their totality, cumulatively, can get us to a meaningful change. So I know that many of you have engaged in thinking through this and coming up with some actual ways of testing it out in practice. So I would like to invite not just our panelists, but anybody, I think, at this point, to talk about their experience. I know Brian's here, Sophie's here, Jeannie's here, many other colleagues who I'm sure have done wonderful things.
So I'm wondering if I can chime in a little
Yes.
bit. So Eva, nice to meeting you again. Right. This is from Peer Voice. So I want to share like my thoughts about this because I have a mix of background. I worked in CME for about 5 years. But before that, I was working in academia doing research, kind of like academic research. And then afterwards, I worked with a healthcare consultation company where people were using Medicaid data like to analyze doctor performance. So they were kind of really rigorously coding the data and then apply modeling towards like a doctor performance score, and then we can score doctor performance. So, and then I work with evaluation, like nonprofit evaluation for a long time as well. So like by seeing all the different methodology being used in research and evaluation field, my understanding is the choice that we make in terms of how we evaluate is largely dependent on the resources we have. And I think that's the major challenge we're having right now for the CME. Like everyone dream about getting access to the medical claim data because that looks like the golden standard. But how many people, how many providers are able to get access to it? There's a large emphasis and a favorable preference towards objective measure, but I felt that gave a lot of providers like us, like a lot of pressure of chasing around approach we cannot apply appropriately or we cannot get financially, versus spend time think about if this is approach we can afford or we can get support on, how we can do it better. So for instance, survey is actually the most usable and the most applicable practical tool for most of provider. But then there's thoughts about survey is subjective, right? So people worry about the objectiveness of the survey. However, we have to remember survey still plays the huge role in the history and as of right now to get people's opinion, to measure people's behavior. So I used to do research about a lesson problem behavior, which is the most difficult thing to measure using survey. However, we were able to make progress on theoretical model, conceptual model using that methodology. So I think the question is maybe not about which approach is better than the other, because there's limitation and strengths of each of them. Maybe the question is, given the resources we have, what is the best strategy? What is the best approach we can do? And we can do appropriately. We should not adopt this approach because it's preferred by the industry or provider, knowing we cannot analyze it properly. We should pick the one we're most comfortable with and have most control over. And then think about, if that's the approach we have to take, how can we refine it, improve it, so we're using it more rigorously? And I think that voice needs to be heard, because like everyone is chasing, like talking about like claim data, and then they forgot, are we doing like the basic measurement the right way? Are we asking the right knowledge competence question? How can we improve the quality of the question? And then if we have to use subject measure to measure clinical behavior change, what approach we can use to get more objective measure out of subjective reporting? I think there's just a lot for us to learn for using the traditional approach that is like more available to the larger providers out there.
Thank you. Thank you, Pam. So that's a really good setup for maybe what we talk about next, which is still in the realm of what's meaningful. I think that's the common thread we have here. And it's the question of context, right? Different context. But it's also a question of not only what are we measuring, but why something changed and under what conditions, which is a sort of the scholarly approach to this question. And I don't think we pay enough attention to that. And there are certainly different ways of thinking through that prism. One of my pet peeves is that we are looking at outcomes, really high level outcomes, without setting up the process properly. And what do I mean by that? I mean that we don't, like Stephen Billet and others thought about the readiness for learning. And we don't even assess that. We are not starting at the same level field with our learners. We don't know if there's this thing called dispositional knowledge he talks about, which is the area of values and emotions. And so without aligning that with our knowledge and process and outcomes changes, we can't even begin to cross the barrier of reaching somebody within the learning activities. So there's a lot to think about. I know, Brian, you talk about the process as an outcome as well in your thinking and your writings. And so maybe you want to say something about that. Sorry for putting you on the spot here.
It's okay. I've been standing upright for 7 days with a bad back, so forgive me if I'm a little disjointed. Whether you apply the trans-theoretical model or any of the behavior change models, that dichotomous approach to change is, I think, really, really limiting to the community and to those that measure things. And Mila, I caught a little bit of what you just said there. The idea that the complexity in systems, as Dr. Price pointed out, versus the complexity in our own cognition, it is a universe inside a constellation inside a universe as to the complexity we're dealing with here. And so many good comments. I just lean back to whatever we're doing, do it in an evidence-based or rigorous manner. Get the best out of your measures. Trying to shoot for the stars when you're asking true false questions and then trying to apply effect size or statistics over the top of those things is just a mismatch of epic proportion. So small steps within whatever system you're operating to find as much rigor as you can. That's all I would ask.
I mean, I think, Brian, you touch on a really interesting point. And it actually shows that we can be as sophisticated as we want, but we might be in different situations. My question is, could we actually align for certain circumstances? And Dean Jenkins actually said in one question, what tips do you have for measuring outcomes as part of the learning event? Can we do something, as a community, to align on maybe the 60% case, which we are doing.
So,
Which
so,
might
so I'm sorry,
be,
Eva.
yeah, now go on.
I think Mila was mentioning some of my research. So I basically, and it's avant-garde, it's really bleeding edge. And so it's another thing that I don't think a lot of systems can do. But I spent the better part of the last 5 or 8 years modeling the mindset of learners as they're engaging with content using some behavioral algorithms I've built. And so when some people can say people completed an activity and that's the most they can measure, and other people can say people were correct when they completed the activity and that's what they can measure, and others maybe go a step further and can allude to some confidence statements using modern confidence-based assessments, that's the most. I really like to push the envelope personally. And so using all the behavioral data that we can generate puts us in a position where I believe that without imposing any more on the learner, without asking them to generate data for us, without increasing the burden, without providing value, by just watching the way learners behave, then I can, in many ways, kind of predict where they are in a state of reflection, or to Mila's point, their intention to change, or their autonomy and self-direction in a learning experience. And I think the takeaway of all of that is, surveys do what surveys can do, and I would never begrudge somebody from applying surveys. Self-report has its limitations. We know self-report has. But in almost every system, the biggest challenges that we're facing are this expectation that we're going to ask the learners to give us data, whether it's methodologically rigorous or not. When you get open rates and survey response rates of 4%, 3%, 5% at best, if you're outside of a closed system, there's just too many misapplied motivations to expect learners to give us data. So we have to be able to think of ways where we can generate these meaningful outcomes within the reality of the system we operate. It's a challenge.
Yeah. So we have I think several questions that relate from all of you to tips on measuring outcomes in situations of limited resources. And I think we heard that question repeatedly. So not having access not only to data, but to expertise in how to put it all together. And I would just say that run that against the need that both the accreditors and the grantors put us in as providers. So as providers, when we're designing interventions in our programs, we push to report high-level outcomes, or we will not pass the muster of accreditation system or receive funding for our education. And so I kind of think that there's something there that's not helpful in the overall process and runs against this idea that Brian, you talked about, which is honestly, meaningfully measuring what we can, what we have at the point of learning and point of care, hopefully. Anybody? David, start with you.
The limited resources question is really, really important. And I admittedly have been spoiled by working my career in relatively well-resourced areas. I think one way to think about what do I do when I'm resource constrained is you still have to use data somehow. But it's not to overclaim what you're trying to do. So if you think about that, unless you work for a group or your job is, I want to increase people's knowledge and all I'm going to do is get them from 60% on the pre-test to 90% on the post-test. If that's what you can do, and if that's what your job is, like one of the places I work for is a board certification group right now, and our job mainly is to make sure that people can do a lot of things, but passing the test is one of them. So if that's what you can do that kind of pre-test, post-test stuff, but don't claim you're doing more than that. So recognize that in the problem you're trying to solve, in taking better care of patients with X, you're going to tackle knowledge gaps. And you've shown that there is a knowledge gap, and your activity, your CPD activity has gone from this pre-test to this post-test. You've addressed the knowledge, but be transparent that you're not addressing competence in practice and patient outcomes because you can't. So be transparent with what you're trying to accomplish, and position your work as a resource challenge CPD group to making one small contribution toward tackling the larger problem. Mila mentioned contribution a little bit, and I am not an expert by any means in contribution analysis, but basically the concept is we in CPD face a lot of pressure to say that I did an activity and it changed the world.
Yeah.
Well, that's not practical for most cases. There's lots going on in the world outside of the CPD that we do. People in different practices have different constraints, they've got different priorities, they've got different amount of resources and so forth and so on. So when we do, here's our CPD, here's our outcomes, there's a lot of other stuff going around. So trying to get out of the mindset of thinking linearly, A, therefore B, think about, we did A, but there's B, C, D, and E, and then something changed and there's this black box in between, and we can say that we made a contribution, we don't know if it's 5% or 10% or 50%, toward improving that outcome. So that hopefully will be a little bit reassuring that we don't have to know that our CPD changed the world. The second piece of that is what we tend to measure is I did A and it worked, and I did A and it didn't work. But there's this whole big black box of why it worked or why it didn't work.
Mm-hmm.
So qualitative analysis, mixed methods analysis is very important. So I got this result. Why did I get that result? So this is where those who do surveys or interviews or focus groups can use those sorts of methodologies, which don't have to be super sophisticated if you're resource challenged, to talk to 5 or 6 of your attendees. Did this work when you tried to put it in practice? Why or why not? And just generate a list of learnings. The positive learnings might be something that you can then provide to others and say, if you want to implement in practice these sorts of things, here are 3 successful things that some of your peers did that you might want to try. Or here are some things that your peers tried that didn't work. So think carefully if you want to try those same things, or think about how you might adapt those things to your context before you go down the same road and try to do the same thing and expect different results. There are lots of sophisticated ways to do that. I'm intrigued by Brian's work about using algorithms and the sorts of predictive analytics. I'm butchering it, Brian, so forgive me, but those sorts of things to predict the sorts of behaviors. We haven't even touched upon AI and machine learning yet, and that's probably a whole symposium. But who knows what that's going to be allowed to do us. But getting back to the resource challenged groups, ask a few people, put together some narrative. And that's something that I believe that most resource challenge groups can do to start getting at, it worked, it didn't, why did it work, why didn't, what can I learn from my learners that might help others? Those are things that I hope you will find practical to do. And again, remember that you're not trying to change the world here, you're trying to contribute to a larger effort that gradually makes things better. Hopefully a little bit reassuring, as messy as it is.
Thank you so much, David. I really like how you have linked this to both the learning science, right? What we know from that, but also the quality improvement methodology. So maybe talk a little bit more about that PDSA cycle and how we don't necessarily, even the limited outcomes, whatever kind of outcomes measurements we use, the question of so what and what happens next is still up there unanswered. and how much do we really use what we learn from whatever methodology we are using in outcomes evaluation to inform and iterate learning environments. And so I think that's a very important piece of the puzzle as well. Does anyone else have a burning question or an idea you'd like to contribute? Just unmute yourself.
Or also from a regional perspective, I know we have Farhan also on the call, who is from Pakistan, so a little bit of a different region here. Farhan, anything, you know, from your side, and from, you know, the environment you are working in terms of outcomes? And sorry to put you on the spot now. Oh, I think he's gone. No, but I agree, Mila. I think it's very reassuring, David, what you're saying. We don't need to change the world completely. And sometimes knowledge transfer, if it's done in the right way, is also important. And I'm coming back, Christina, you know, to your environment. And I think you also see a lot of pushes, right, from your management, but also for working with CME agencies, that sometimes we try to reach a little bit too high and we cannot really measure.
Sorry, I'm back then, Farhan. Yes, Eva, I'm back.
Oh,
So
hi.
yeah.
Okay.
Yes.
Good.
So yes, we are still novice in our region, and basically we usually do our CMEs based on our need assessments and surveys usually. So we try to explore the needs of the physicians, and because if we talk about the data is not well organized, data is not here in our region, in my context I'm talking about, right? So we usually plan CMEs based on the learning needs of the physicians, or most of the time CMEs are usually pharmaceutically driven. So, but working in an academic setup, usually the CMEs are organized based on the learning needs of the physicians. So do I answer your question, Eva?
Yeah. No, this is really good. Yeah, no, because we just wanted to get a little bit of perspective globally. Anybody else? I know we have Europeans on the call. We have colleagues from the US on the call.
Canadian colleagues.
Canadian colleagues, Sophie.
Sophie and Jeannie in particular. I know we work together on communication curricula and sophisticated and complex evaluation outcomes in that context. And it was really mixed methods, David. a lot of soft stuff, you know, but that's the link of matching what you are teaching and the competencies you're teaching with the instruments you're using to measure outcomes, let alone measures. A lot of attitudinal stuff, a lot of engagement stuff, a lot of changing culture as an outcome. We haven't talked about that. So maybe Sophie or Ginny, you could contribute.
Well, if I may provide a little bit of Canadian perspective, and as I was listening to today's discussion, I thought, and you're talking about a change in culture, we are collectively changing the culture of what, as a stakeholder group, we think about outcomes. I know in the past few years, we've seen a change in many of the supporters' expectations regarding outcomes. There was some discussion in the chat there where we've heard from supporters saying, well, we understand that if you're doing PI2I, you won't see an effect in 3 months down the road. Maybe you need to wait 6 months. Maybe you need to wait 1 year for these changes to have time to show up into an EHR, for example, right? When before it would have been, well, we want data by the end of the year, and you have, 12 months to execute on this grant, for example. So there's an evolution from all stakeholders in what we are, how we understand outcomes, what our expectations are, what we know, to David's point, what we know we can contribute to as part of, you know, a greater scheme of things. I think this is inspiring to see that. And for sure, we're, to your point, Mila, our team has always been, you know, really strong advocating for qualitative perspective, but it's also because we believe that with this qualitative piece, you are able to capture and understand a little bit more the process that you're contributing to with your education, that is this behavior change process, and also the barriers to change that clinicians might be experiencing. And that means that maybe your education won't have the impact that and were intended to, or not exactly the same one, because of all these factors that are outside of the scope of the education per se, but that are influencing how clinicians are able or not to implement in practice.
Yes, thank you. Thank you. We don't talk about negative outcomes enough, and allowing people to, for lack of better language, fail while problem solving in the learning environment. And that's critical for learning, as we know. So how often do we structure it that way? Or we look at the barriers and try to problem solve and you know, take negative outcomes and learn from that. I think that's important.
Which would be very important, right? Because we said we are resource limited in many ways, and knowing which learning activity really has an impact, and where do we have problems with a learning activity, and how could we make it better, or maybe not to do it in this way again,
Right.
would actually also save resources, right?
Yeah, but asking, you know, probing deeper and figuring out why something works and doesn't,
Exactly.
is a learning process.
Most of the things we do are going to fail.
Yep.
Yeah.
Which is fine as long as we learn from it.
Yep.
Yeah.
And this
But
is,
we all, I think, David, yeah,
Go
sorry,
ahead.
Mila.
Go ahead.
We all need to be prepared to do that analysis and to include that analysis into everything we do. And I just can speak from my perspective that it's not easy at some point, but it's super important to encourage internally to learn from our failures, which is super important. And it's something that probably, Sophie, to your point, it's a cultural mindset change that we all need to focus, and it's something that we all need to include in our analysis and in our thinking. It's super important. Yeah.
That's right. So cognitive psychology and on, we know that people learn, and we are all people, including physicians, more from mistakes than
Sometimes physicians are people.
They always are. I think we are all very human. So before we actually close, I would like to ask everybody to give us a quick feedback, you know, in the chat of what was the most important thing you heard today from our experts, what are kind of take-home messages or aha moments, you know, you had in this hour. Would be really interesting for us. And I think Mila might be last round while everybody is typing away.
Well, I just think that it's important to think about engagement as an outcome, as a destination, if you wish. And so if we take even an activity like this, it's about learning from each other. It's about a dialogue. It's modeling collaborative learning and problem solving, which hopefully is matching to collaborative models of care that we say we are engaging in these days in healthcare. And I think as much as we can do that longitudinally with different well-matched modalities of learning is a way to reaching meaningful outcomes. And I'm really honored to be here with all of you, certainly with David and Eva and Christina and the colleagues I know, but also those I don't, and be part of this group at GAME, because it is such a versatile group with different perspectives. and both geographically and stakeholder-wise. So, Christina, would you like to add any final remarks?
Well, to me, Mila, I think it's important to have these kind of forums to learn one from each other, because to me, today has been super inspiring. And I think it's important to build together what the outcomes are for all of us from the different perspective, because in the end, I think that reading the chat and listening to all of you, the main outcomes is the same, to help as much patients as possible. So to me, it's really important to build together how good looks like for all of us in terms of learning and sharing this learning together. So to me, that's the most important thing. And in the end, to revisit the basics, which is important, and don't forget about the basics in measurements, that it's really important not to forget.
Thank you. David, any final thoughts?
As I listen to the conversation, particularly through the perspective that there are those of us who work in differently resourced environments, I'd like to leave you with the concept of stress versus strive. So for lower resourced entities, don't stress that you can't get to the higher level outcomes. For those of us who are in better resourced environments, don't revert to the lower level outcomes when you can actually measure more. So all of us, no matter what environment we work in, should be striving to get to those higher level outcomes. For the lower resourced environments, it might take you a long time to get there, or it might take fora like this to be able to talk to others, to have some ideas. For those of us who work in higher resourced environments, we might be able to make those connections more easily, but always strive to get to measure higher levels than you're at right now. Don't stress too much if you can't, but don't give up on it and keep trying to get to the next level of outcomes. That's my hopeful way to balance stressing, but continue to strive to improve.
Thank you so much. Eva, thank you. I want to thank you for inviting me to be part of this discussion and for starting this forum of the President's Dialogue. I think it's terrific.
Yeah, thank you very much, Mila, for co-chairing with me here. Thank you very much, David and Christina, for being our expert panel. And I would like to thank everybody for spending a time of your time with us on this webinar. We will have it on demand, and this will not be the last in the series of President's Dialogues. So please stay tuned, and I hope I see you next time again. Thank you very much.